Thank you, and thank you to Reprosex for having me. Also, thank you for including something about men. So prostate cancer. This is a cancer which occurs mostly in older men over 50, which with a much higher incidence over 65. It's the same in other parts of the world as in Sri Lanka. And it's not a cancer that is involved with a lot of risk factors which you can prevent, but there are some known ones like family history. If a man has a father or brother or close relative who was diagnosed with prostate cancer at less than 55, or if they have family members with cancers associated with BRCA gene mutations like breast, ovarian or pancreatic cancer. It's known to occur more in African Americans, and it's less in our part of the world. And there are some dietary factors vaguely associated, like increased red meat, processed meats, and less fruits and vegetables, obesity and lack of physical activity, and also chemicals like those found in cigarette smoke, vehicle exhaust fumes, DDT, and cadmium. So the early symptoms, this is a cancer that doesn't give early symptoms, right? So like the symptoms they do get somewhere in their disease are due to, obstruction of urine flow. And mind you, obstruction of urine flow is not just due to prostate cancer, it can be due to benign prostatic diseases. But it's important to make men aware that it could be a cause. So frequent urination, difficulty in starting urination or holding it back, weak or interrupted flow. Also less common, they can have burning sensations or discomfort in the pelvic area or blood in the urine or in the semen. Late symptoms are more severe, and if they have bone pain, you have to think whether it's spread to the bones. If they have swollen lower limbs, think about whether there's lymphatic spread. And then the general symptoms of cancer are there, like unexplained weight loss and tiredness. They can have erectile dysfunction. In the late stages, they can have loss of bladder and bowel control and complete inability to urinate. Treatment depends on risk stratification. There are several methods of stratifying risk. Most of them use the Gleason grade and the PSA and the stage of the disease. So this is a tumor, interestingly, which if it is slow growing, men can live with and die of other causes, right? So those are called low risk tumors, and they are offered what we call active surveillance, where they have routine checks for PSA or digital rectal examinations or biopsies at regular time intervals. This is a bit of a problem in our setup because in the state sector, people might just trot off and never come back again. Right? So still for all that is the option for low risk cancers. And higher risk cancers, in our country, it's mostly radiotherapy because there are too many surgical complications from radical prostatectomy. But in the West, where they have perfected this more, there are a lot of radical prostatectomy still happening. And if it has spread, you can give other treatment options. Right. Now I come to my first key point. Prostate cancer in Sri Lanka is probably still underreported. Professor Chandu De Silva back in the 90s published a paper on this, that it's underreported, and things have improved since then. But even in the 2021 statistics, it's the 5th commonest cancer in Sri Lanka, whereas in 21 in Western countries it was the 2nd commonest. Now in USA and in UK, it's the top cancer in men, right? So I still feel that we're missing something. Right? It's only 7.5% of the cancers in our men. This is the latest data available. Right? Now, PSA testing is a double-edged sword. There are good things about PSA and bad things. The good things are that it's known to reduce mortality in high-risk populations. It's just a blood test. And there are newer modifications like PSA density and velocity, which are supposed to increase accuracy. That being said, it's known to have false negatives, false positives, interracial differences, interlab differences due to the testing technique they use. And this, as I said, it can be a slow growing indolent cancer. But if the man knows he has a cancer, then he's going to be anxious and go ask for various other investigations which may not be necessary, right? PSAs are expensive. In this country, in the private sector, it's like 10 to 11,000 bucks, right? And also, the cutoff point, it has always been traditionally 4 nanograms per ml, but there is debate about this cutoff point. It may depend on the age, etc. That's my next point. Most of our cancers, prostate cancers, are high grade, unlike the West. Okay? Now, what's grade? It's defined by this thing called a Gleason score, right? And what we do is we look under the microscope for these patterns that we see, right? And then we, it's a combination that we give of 2 patterns, usually the predominant pattern and the worst pattern. Now, of these 5 patterns that Gleason originally divided it to, nowadays we don't even call the first 2 cancer, right? So then we have basically 2 patterns we are dealing with. 3 patterns, right? Now, grade groups are a newer modification by the WHO, where they took all the possible combinations of the Gleason scores and divided them into 5 grade groups. Okay, this is simpler to do. Okay, and it provides better risk stratification. You will notice that the 7s have been split. Okay, with the ones that have predominantly pattern 3 cancers and ones that have predominantly 4, because they behave differently. So they are more, it's more accurate in risk stratification. Also, imagine telling a guy you have Gleason score 6 cancer out of 10. He thinks, oh God, I'm dead, right? But it's actually the grade group 1, which is the most indolent cancer. So grade groups reduce over-treatment because they can better distinguish aggressive and non-aggressive cancers. But nowadays, we are still evolving, so we give both in our reports. Some urologists use Gleason score still for risk stratification. Right? This is the future. Molecular tests, artificial intelligence for grading. Even now, there are modules online which do AI grading of prostate cancer. But this is still not in clinical use. Right. This is an ongoing study, and at the moment we have about 345 cases from 4 centers, and our mean age is on par with other studies in Sri Lanka, older studies. And this was a question I had when I came back from UK, because in UK you have very small quantities of very low grade cancer, and here it's teeming with high grade cancer. So I wanted to see whether this is actually true. And so far, it seems true, because 20% only are Gleason score 6, and the rest, 80%, are 7 or higher. Grade groups, you can see it's equally spread across the grade group. Now, we compared this with a study from Colombo North. Gleason scoring has evolved, so you have to compare it with newer studies. And then our findings are similar, and you can see that the Gleason score 6s are less than the higher grades. Comparing it with a study from UK is different. Okay, this is Dan Burney's study, and his one is in blue, and you can see that they have far less of the grade group 4 and 5 cancers, and we compared with our grade groups, which are going across all the grades. My next point is that most people don't die of their prostate cancer. This is 2021 from Sri Lankan Cancer Control, NHS UK and CDC USA, and you can see the death rates are pretty low, especially in UK, right? So, but in our country, this is NCCP data, and the prostate cancer death rate is slowly creeping up, whereas in the US and UK, it is definitely going down. So now we have a lot of high-risk cancers, high-grade cancers, right? Even Balagovi et al. Did a study in Jaffna, found 80% of their cancers are high risk and less deaths. Why? There are probably several reasons for this. One is grade migration. As I said, Gleason grading has evolved, so some of the things that were lower patterns are now higher patterns, so then the overall grade grows up, right? But that's a small factor, because even the older studies had less low-grade cancers in our country, right? But the more important factors are, this is a slow-growing cancer, so most of them probably don't die of it. We don't know how many cancers we actually have, right? And there is a severe dearth of follow-up data, so we don't know whether they died of them or not. In 2020, I was happy to be a part of this, and it states that PSA-based screening should be done if the patient, if the man is over 50, or if you want to do it in a younger person, they should have strong risk factors. If the PSA is high, refer to a specialist for further evaluation. Avoid over screening, that's stressed. Okay, balance the benefits with the potential harms. And when it's confirmed, refer to oncology immediately. Now, that's my last key point. It's really difficult to do prostate cancer research here, because in the government sector especially, there are very few clinical databases being maintained. We can't even get the PSA values of patients, right? And even the data we have is not uniform. People are re-stratifying in various ways, testing PSA in various methods, etc. And there is no integration with our pathology data or the radiology data. So, basically, the public and primary care physicians should be educated that although prostate cancer is mostly indolent, there can be aggressive tumors, and the purpose of screening is to catch those aggressive tumors and not to treat the ones that are indolent. Over-screening is not advised. We have perfectly good guidelines which should be followed, and although it's not strongly linked to a lot of risk factors, things like smoking, which are preventable, should be avoided. And for tertiary care centers, it's time we established good databases. And I think the colleges have a role to play in establishing a dialogue for this. And those databases should be comparable. So there should be standardized PSA testing methods, radiology reporting, biopsy protocols, pathology reporting, risk assessment, and treatment protocols. Thank you.
Your presentation brought light some critical aspects related to the prostate cancer, particularly its diagnosis. Our panelists here are to provide further insights. So please take this chance to ask questions from Professor Isha related to her presentation.
I think so. And, like the lower urinary tract symptoms, okay, as I said, it could be benign, but men tend to ignore this, put it off, and I have a hunch that they are presenting late. Yes.
So what do you think would be a best strategy going forward? Maybe with
Well, public education is good, and this can be done in a variety of ways. Pretty simple. I mean, not just having like you have breast cancer campaigns like that. Okay. Okay. So yes, yes, right. So other than having little meetings in person and education webinars and stuff, you can also do one thing we need to do in this country is partner with the primary care setup, because that's where the the rather illiterate, less educated people are, and they are the ones that we can't reach, and they are the ones who present late, right? So partnering with the primary care setup is important. And then of course there's social media nowadays, which can use celebrity endorsements, influencers, the list is endless, right? And I mean, you can do really one of my friends who's a urologist was saying, you can just put stickers on public urinals. Yes, you have difficulty in urination, go and see a doctor, It's very simple, right? Actually, there was a very interesting project done by a student in design, where they designed a beer tower, where the more beer you take out, the less comes out. So it's like decreased, like a urine obstruction. And then it says, if you have this problem with urination, contact your doctor.
we should put it in the vase. Thank you so much.
So you have given the mean,
yes,
some 72 years
yes,
or something like that.
Yes.
So I presume that the age also a major factor for the prostate cancer.
It is,
so,
because
high
like
correlation.
Yes.
Yeah.
It's
so could you
less than 50 is extremely rare.
Yeah. So could you tell me that the median of age group, whatever that 45 to
yes,
93.
we have this is like an ongoing study. We haven't really looked at the median yet.
Yeah, that
but yes, exactly.
Yeah.
But we did notice that a large chunk of them were over 65.
Absolutely, yeah. Because
Yes.
age is a major factor. Yeah,
Yes.
thanks.
Okay, thank you, Professor Isha. Now I would like to invite our next panelist, Dr. Kanchana Vijayasinghe.